Live vaccines are some of the oldest vaccines in the schedule, so although they engender a certain bit of nervousness and the contraindications, particularly with regard to immunosuppression, need some talking through, they are actually the most established vaccines in terms of the past history. And they're important vaccines because they protect against important diseases like measles, mumps, rubella, rotavirus now, polio in the past, and TB with BCG. And they're important because they engender good immunity. So they effectively give you a small version of the infection, a very mild version of the infection, and so give you long-lasting often immunity that stimulates all the different pathways, so B cells and T cells. But they are old vaccines. So just to recount a bit of history, one of the first vaccines in history possibly was a vaccine against a thing called cutaneous leishmaniasis. So this disease is a parasite. You get a bite from an insect and you get a nasty scar, and often it's because the insect's bite where you're exposed, it is the face or the hands, and people are aware a long time ago that if you inoculated a bit of the material into the skin on a site somewhere other than the face, you would get your infection, it would be out of sight, and then you would have immunity. So in a way it's using the actual organism itself and just choosing the time and the place you want to be infected. So then you could have a beautiful face and your marriage prospects wouldn't be altered. That was recognised a long time ago, a little bit like the chickenpox party in a funny way. You choose your time to get your dose of pathogen and get it dealt with. Smallpox is the other one. Here's an example where we used a viral vaccine, where we used a species that wasn't human. It was the cowpox virus, and the milkmaids got infected with that, and then had immunity against the smallpox virus. So both of those are live vaccines. And all these vaccines are similar in one way. We take the original pathogen and weaken it, either by this method B, where a virus, and in this case it was a mumps virus, was taken from a throat and then grown in eggs or some sort of egg-based culture. And the reason there are lots of eggs there is because it was grown once, and then the virus was taken, it was grown again, and then the virus was taken, it was grown again, and then it was grown in some culture medium, which is the Petri dishes. And at the end of it, you end up with a virus that through all those different passages has grown used to growing in culture or in eggs rather than a throat. And viruses and bacteria being what they are, they get mutated. And actually it's no longer quite as good as it was at growing in the original throat. And in fact, this apparently was Dr. Hillman taking the virus, I think, from his child with mumps and serially culturing it to form what eventually became the Gerald Lynn strain of the mumps virus. So by getting it to grow repeatedly in environments which it's not familiar with, it changes the way it grows and causes disease. And the trick is to weaken it enough through that it doesn't cause disease, but keep some sort of looking similar enough to the original strain that it actually can generate immunity that protects you against the strain. And so for many bacteria, BCG for instance, viruses, measles, mumps, that sort of serial passage has been the way that the vaccine strains have been developed. A more modern way in which people are exploring now is now you can look at the genetic mutations. You can perhaps predict for any virus which mutations you have to introduce to weaken it. And so are people busy genetically engineering typhoid strains or other strains of bacteria and viruses to weaken them in a planned sort of way. I think that's meant to be a computer and some sort of device for manufacturing viruses in the middle, but it's some sort of predicting and mutating viruses. So that's how we weaken them, that's how they're produced. And very similar principles behind all of those. And of course it's of increasing interest to us because now more and more vaccines are in routine use. And I'm going to cover a little bit more in detail the issues around BCG, which is usually given around birth, rotavirus, which has come along in the last year and is a little bit in a way like the smallpox. It's across, this one is a human virus, but there are rotaviruses derived from other species like cows, but it's not the one we use. MMR, which you're getting at around a year, and then the preschools, and then the increasing use of the live flu vaccine. We might touch on chickenpox, yellow fever and oral polio. Through all this, one of the major things I want to talk about is immunosuppression, and because that's one of the things that makes the vaccines quite different from the others, is that Potentially, in some individuals who are immunosuppressed, the viruses, which are causing a weak form of infection anyway, which are actually replicating, can get out of control and can cause severe or life-threatening infections. And so that's a major issue. Who are the children in this case, but who are the individuals who you wouldn't want to give live vaccines to? And I guess the other issue with these vaccines, and this was familiar in the days of oral polio, is that these vaccines can be transmitted to other people. So if, in some cases, so if you have an oral polio vaccine, you shed the virus in your poo for the next week or two, and if you live with someone who's immunocompromised, that could potentially infect them. Now that's not true, not every vaccine can be transmitted, but some of them can. So immunosuppression is the thing we want to talk about mainly, and the immunosuppressed are a bit unlucky. They're the group who are at higher risk of infection, and so one would want to give them all the vaccines one could. And there are in fact detailed guidelines now from the Infectious Disease Society of America, who published them last year, on how to immunise the immunosuppressed. Very often they can have all the inactivated subunit vaccines, and they should, depending on what their particular immune condition is. But live vaccines potentially cause a problem. So who would you count as immunosuppressed? The first case is primary immunodeficiency, and so these are very rare individuals who have a genetic abnormality that knocks out part or a large chunk of their immune system and predisposes them to infection. And they are extremely rare in the population, and there are a wide variety of different immunodeficiencies, ranging from ones such as SCID, which knocks out all your T-cell immunity, to agammaglobulinemia, which knocks out all your antibodies. And these are children who come to us in the clinic with often very profound, severe, unusual infections, and have very particular treatments. And in them, as a general rule, we would completely avoid all live viral vaccines. The group in red are the group who are very identifiable because they're either being treated for a malignant disease, a leukemia or lymphoma, or they've had a transplant or on immunosuppressive drugs, or they're post-bone marrow transplant. While they're on treatment, while they're immunosuppressed for long periods after treatment, live viral vaccines are contraindicated. In some cases, after they've finished their treatment and they've had a good interval, people re-immunise these, and usually the teams who are dealing with them have very strict protocols for that. But in terms of the children you'll see, these are very readily identifiable in the community. The other group are people on drugs for other conditions, and particularly steroids. And the definition given in the Green Book of someone who is immunocompromised on steroids is someone who's had a dose of 2 milligrams per kilo for a week. And 2 milligrams per kilo is probably the upper end of a dose we'd give for some asthmatic children who might have 2 or 3 days, or 1 milligram per kilo for a month. So the lower dose you're on, the longer you've had to have it before you'll be called immunosuppressed. If you're on less than a milligram per kilo for a very long duration, that may also still be a problem, and I would definitely speak with someone before administering a vaccine in that situation. And the general advice is that you should be off your steroids, your high-dose steroids, for 3 months before you receive a live viral vaccine. For other immunosuppressing drugs, and there's a huge range of them, and it's ever expanding, things that we use for rheumatological conditions, rheumatoid arthritis, things like that, methotrexate, azathioprine for inflammatory bowel disease, and then increasingly strange drugs that knock out very specific enzymes, and the only one I've picked up there is imatinib, which is some sort of enzyme inhibitor that the oncologists use now. The recommendation is that you're actually off them for 6 months before you have a live vaccine. So these are general rules. There are some exceptions, and I'm aware that in some rheumatological conditions in very well children, people on low-dose methotrexate are receiving varicella vaccine here with the paediatric rheumatologists. But that's a practice that is not completely evidence-based at the moment, and there is more data being gained. And in general, these rules are one would take as initial guide for whether someone had a live viral vaccine. HIV is interesting because it's a reversible immunosuppression, in that once you're on treatment, your white cells come up and you get you have much better immunity. And so HIV, although viral vaccines would be contraindicated while you're well or immunosuppressed, we do give chickenpox vaccine and MMR once they're in a stable treated state and their white cells above certain thresholds. The things that don't count as immunosuppression from a point of view of vaccines would be inhaled steroids or topical steroids, or someone who's having an intra-articular injection of corticosteroids. And also a rare group of individuals who are on maintenance doses of steroids because their own adrenal glands don't produce them. In general, other immunomodulating treatments, whilst they might affect an immune response, aren't considered a reason not to give live viral vaccines. So something like gamma interferon. One might choose to avoid giving them during a period of treatment, but they're not contraindications. So I was going to cover now the four vaccines that are given in the first year of life that are live. And the first one is vaccine against TB. So the BCG vaccine, one of the oldest vaccines in the book. It comes from Mycobacterium bovis, which is a bovine strain of TB. And in the 1800s, 1900s, people were quite impressed by Jenner's work on taking bovine, cowpox virus, and tried using Mycobacterium bovis as a vaccine against TB with predictable results in that people got disease. Mycobacterium bovis on itself wasn't attenuated. But two scientists, Calmette and Guérin, if that's how you pronounce their names, who were interested in culture medium for mycobacteria, noticed that in some media it didn't seem to grow as well, and they then serially passaged over several years the Mycobacterium bovis through the culture and weakened it, as we showed before, and produced an organism that was then attenuated. I think it had some difficulty convincing people of that in the first instance, but has now been in use for decades, one of the longest and most serving and widely administered vaccines. Now, we give that to children who come from either regions of this country or who belong to families from regions of the world where the incidence of TB is above a certain level. I think 40 per 100,000 per year is the sort of figure. But and the normal course of BCG, which is a little intradermal vaccine, slightly awkward to give, is that you get after a week or two a slight red papule there, and you've probably all seen it, and then it discharges. And I was absolutely astonished. I had 4 children immunised against this of my own all at one time. And my wife was asking me for weeks afterwards whether it was normal to still be discharging pus. And I was just impressed afterwards at how long the sort of reaction had gone on. They're all still alive, so Andy may be looking sceptically at me about whether I should investigate them. They're all still well. But it can discharge, and you can get quite significant swelling and pus for some time afterwards. And also you can get nodes under the arm, and here's a typical reaction, maybe slightly more severe than some on the arm, and a node under the arm. We see quite a lot of children, very well otherwise, with just something local to the side the BCG was given on. You can get disease from BCG, so the rare children with conditions such as severe combined immunodeficiency or HIV that was actually symptomatic where they can't actually control the infection, they don't just get local disease, they end up with nodes elsewhere. They end up with fevers, they end up losing weight, they've got a large liver and spleen, they're not well. And we're treating one child like that at the moment, and they've got a very specific primary immune deficiency from a consanguineous family. They're actually been very well, but they've got nodes everywhere, very chunky nodes. But you will see a number of children with a single node or a pussy reaction, and in an otherwise healthy child that would be completely normal. So the contraindications to BCG would be previous immunisation or previous infection with TB, and anaphylaxis to any component of that vaccine, and immunocompromise, all the groups we've talked about previously. With our children, with HIV, it's a vaccine we avoid completely. Even if you've reconstituted immunity and you're on treatment, we don't give BCG because of its particular synergy. HIV and TB, mycobacterial infection. In our children who are born to mothers who have HIV, we actually delay immunisation. Now, the chance, if they're managed properly, of contracting HIV if you're born to a mother who's had antiretroviral treatment and had zidovudine in labour and had antiretrovirals in the baby afterwards is extremely low. But the baby has a low risk of exposure in the first weeks of life, and we choose to defer it to 3 months so that we can confirm the baby's uninfected, and then we give BCG. There aren't really any alternatives to TB vaccines, to BCG as a TB vaccine at the moment, although people are working on that here in Oxford and other places. Rotavirus is the next one we're going to deal with, and there's from the Green Book, the annual winter peaks of diarrhea and vomiting disease. And we're hoping those will gradually get less and less, and as the vaccine is introduced and widely used. There's the age profile with the disease clustering into the young children. I've just been on call all this week. I don't think we've seen that much diarrhea and vomiting, so maybe you're all doing a good job and sorting the children out with their vaccines. It's a live attenuated vaccine. Rotarix is serially passaged from a human virus, a 15-month-old who had rotavirus. The virus was isolated, I don't know when it was, passaged through various viral cultures and weakened in that way. The routine programme at 2 and 4 months is now in full swing, and some children will get a little bit of tummy upset having had a rotavirus vaccine, but normally do very well. They don't really have many side effects at all. Disease from live attenuated rotavirus actually isn't highly described in the literature. There are a few cases, and the cases I'm aware of are all children with a very rare severe combined immune deficiency, which presents sometime in the first year of life with recurrent infections. And actually those children have really had prolonged and protracted courses of diarrhoea, sometimes enough to make them quite dehydrated. And then the virus has eventually settled down once they've had bone marrow transplants. The contraindications, again, would be anaphylaxis to the vaccine previously. Clearly with rotavirus, there are some very prescriptive guidelines about the age you can give it at because of the previous association with interception with delayed doses. There are some contraindications around previous interception or gut malformations which predispose to interception, which I can't think there are huge numbers of. And then the contraindication around severe immunocompromise is really around the most severe end, and they particularly point out SCID in the severe combined immune deficiency in the guidance. And with other forms of immune suppression, the guidance is a little bit more vague. It suggested that benefit may exceed the risk in other forms of immunosuppression, and you have a high risk of exposure to natural infection, so you may consider giving it in other immunosuppressive settings. I have to say we haven't been confronted with that question particularly in terms of people were asked about in clinic yet, and I would still give it fairly careful cause for consideration. But the actual guidance isn't quite as blanket for the rotavirus vaccine. In practice, most people at 2 and 4 months of age, no one will know whether they've got any rare immunocompromising condition. For HIV, there's now reasonable data in the places like Africa giving rotavirus vaccine without any undue consequences. In terms of alternatives, the only alternative is another live vaccine, and short of avoiding exposure with other humans, there aren't any immediate alternatives to rotavirus vaccine. So, 2 more. So MMR, again, live attenuated measles virus, the 1940s and 50s, researchers passaged it, attenuated it. The routine programme has the first dose at a year, and that's not because of worries about safety under a year or a weak immune system or anything like that. It's just because because it's a live virus, it replicates. Maternal antibody is thought to inhibit it, and you don't get as good a response under a year. Disease from attenuated measles virus, again, when you look in the literature, there aren't large numbers of cases, but there are clearly cases of people who've got congenital immune problems who present with odd febrile illnesses, often with a pneumonia, a protracted course, or an adult with HIV who's come back and back again with a pneumonitis of some sort. And in both those cases I'm describing, after some months a diagnosis was made, and both cases were fatal in the end. So measles virus clearly, in severe immunosuppression, can cause disease. The normal course that isn't indicative of immunosuppression post-vaccine is that you have your vaccine, you might have a sore arm a day or two afterwards, but a small number of children will get a fever and a mild form of rash between about day 6 and 12, and that's different from your average vaccines because it's quite delayed. But that's because it's following a milder, weakened course of the natural process of infection. It's clearly not quite natural, you're injecting it rather than inhaling it. But that's not indicative of an immune compromise. So again, contraindications include anaphylaxis, include people who've had reactions to neomycin and gelatin, and all the immunosuppressive ones we've talked about. Individuals with HIV will get given MMR providing they're healthy and they're on treatment and their CD4 count is above a certain level. The contraindications in pregnancy, as far as I understand, are relatively precautionary in that there's no evidence that giving MMR in pregnancy results in any abnormalities in the fetus. It's not thought to be teratogenic, but there's not large amounts of data, and it seems reasonable to avoid doing something during pregnancy. In terms of alternatives, there aren't alternative vaccines to live viral vaccines. There are alternatives if you're exposed to measles and you haven't had your vaccine, in terms of giving antibodies, but that's usually if you're immunocompromised. But at the moment there aren't any other alternative vaccine options. So just to come on to the last one, and this will become increasingly part of our lives, I guess, over the next few years as the programme is extended. Fluenz is interesting. It's it's called cold adapted, so it grows better at slightly colder temperatures than it's used to. And what it's used to doing is growing in warmer temperatures deeper in the heart of the body and causing disease. So if it's cold adapted, it grows worse in areas where it would cause more trouble and tends to stick in colder areas like the nose where it's given. So it's got mutations that are introduced through passage. The childhood programme's expanding, and I can't remember this year. Can anyone remind me what age group we're doing up to? 3 or 4. So more and more children. Clearly some snuffliness after immunisation is a possible result of a normal immune response to the vaccine. I actually struggled to find any reports of disease in immunocompromised children or adults from a live attenuated flu vaccine. I'm looking to know whether anyone's seen any reports. We had a case here earlier this year which we got quite excited about in a medical way, but it actually turns out not to be a related virus at all, but it was a patient who'd presented with leukemia having had their flu virus vaccine some weeks or months before. So the contraindications, again, anaphylaxis, immunocompromise. It's okay in stably treated children with HIV or adults with HIV. We avoid it with salicylate treatment because influenza infection used to give a nasty metabolic liver derangement when it was given when you got influenza on aspirin. And the other interesting thing about it is that you can transmit the virus to other people if you're excreting it from your nose over the week or two after having been given it. The only thing it says in the handbook on immunisation really about that is that's of concern if you're immunising around an individual who has severe immunocompromise, so someone who is immediately post-bone marrow transplant or had a child with SCID or something like that. You might actually just be concerned about the possibility of transmitting within families. I don't think for other milder forms or someone on steroids anyone is concerned really about the possibility of transmitting it to them. There are alternatives, of course, with flu vaccine. You can use the inactivated vaccine. So if you have a concern, Fluenz is thought to be the live attenuated flu virus much more effective, but there are alternatives. There are, of course, other vaccines that are live viral vaccines, varicella, which we're not using at the moment, yellow fever if you're going for travel, and there are one or two others. So there are other settings in which you'd have to consider carefully the issue of immunocompromise. But just in view of time, we're not going to cover that now. But clearly, varicella and yellow fever can both give, potentially give vaccine-associated disease in severe immunocompromise. So in summary, there are more and more vaccines. It's unusual to have to think that the setting of immunocompromise sufficient not to give the vaccine is still a relatively unusual situation. You want to wait 3 months after a decent course of steroids or 6 months after other immunosuppressive medication. There are detailed guidelines for oncology and bone marrow transplant patients, and it is a slightly complicated area sometimes when you're actually faced with a particular patient on medication or with a treatment and weighing up the risks and benefits. So if in any doubt, ask. You can ring the team on VaxLine, you can look in the Green Book, and the USA have got themselves together about producing some clinical practice guidelines on immunising immunocompromised individual, which is, I think, a little bit more than we've managed to do over the last 10 years in the UK. Are we meant to be doing that, or coming soon? Okay, thank you.